Good afternoon, everyone, and delegates and members of the panel, and welcome to this ADASS webinar on mental health in the community. The theme is the role of local authorities and approaches to meeting the changing needs of the population during the pandemic and beyond. We have a wide range of delegates from a range of agencies to give their perspective on this theme. And I'm really pleased to be here to sort of chair today's session. My name is Beverly Tarker. I am a Director of Adults and Health in the London Borough of Haringey. I'm also an ADASS trustee and co-chair of the Equalities, Diversity and Inclusion subgroup for National ADASS. As you're all aware, Mental Health Awareness Week is an annual event where there's an opportunity for the whole of the UK to focus on achieving good mental health. This week is an opportunity for people to talk about all aspects of mental health, with a focus on providing help and advice, and for ADASS and people working in social care, an opportunity to discuss how we can best improve service provision. I also want to say thanks to Letitia and Claire, who are on the call, not visible at present, but are members of ADASS and have been instrumental in putting this event together. So without further ado, let me just go on to the first part of the presentation, which is my own sort of reflections in terms of specifically our experience in Haringey. And then I'll talk a little bit about London ADASS's response during Mental Health Week. So, Letitia, if I could have the slide deck up, please, that would be really helpful. Thank you. Thank you very much. So, as I said previously, just going to share briefly some reflections about the Haringey experience in terms of our experience of meeting the changing needs of the population during the pandemic and beyond. The next slide. So just a little bit about Haringey to start with. It's in a London borough located in the north of the city. It's young, ethnically diverse, with a population of just over 270,000. And there are over 180 languages spoken in Haringey. I think it's important to note that there is quite a sharp divide in terms of areas of deprivation between the sort of the east and the west of the borough. And with people in the east of the borough, increased chances of poor mental ill health, unemployment, homelessness, etc. I think these themes will be very familiar to you. The next slide. So pre-COVID, I just thought it would be useful just to briefly share some of the sort of demographics around mental health, ill health in the community as it pertained to Haringey. And I'll just pick out of some of these statistics. It's important to note that during 2019, there were 22 deaths by suicide. There have been obviously some concerted efforts to work cohesively with a range of partners, and we have seen some decrease over the past 10 years, and we're now in line with the national average. 1 in 10 adults in Haringey have a common mental illness, such as anxiety and depression. But more importantly, significantly, there are significant members of our Black, Asian and minority ethnic communities who are diagnosed with a severe mental ill health. Next slide, please. So 1 year on, losses and gains post-COVID. We see a bit of a mixed bag. We've had the sort of landmark UK research about mental health in the pandemic. And I won't go into detail, but just some highlights from that research. Loneliness has risen from 10% of those surveyed in March 2020 to 26% in February 2021. Fewer UK adults feel they're coping well with the stress of the pandemic. And in fact, in April 2020, 73% said they were coping well, but this has since decreased in February of this year to 64%. So unequivocally, we know that the pandemic has had deep emotional impacts. And the next slide, I think I find very useful in sort of reflecting around the experience of the past year as pertaining to all of our mental health needs. We've all been in the same storm, but we've not been in the same boat. Next slide, please. So how are we actually addressing the need in Haringey? I don't need to repeat the oft-said impact of COVID in terms of the widening of health inequalities, bringing it into focus. I've also already mentioned significant impact on Black, Asian, and minority ethnic communities. And we all know that mental ill health is a significant contributor to long-term health inequalities. And I think we are yet to see the immediate and longer-term social and economic impacts of COVID and the potential they have to exacerbate mental health problems. So one of the things we're actually doing in Haringey is to form in a working group through our mental health exec, but very importantly, involving people with lived experience with mental health, so that we can identify issues and work together on how we can pay particular attention to the issues that are being surfaced. We know, for example, that LGBT plus communities, children and young people with neurodevelopmental disorders, and older people have also been very adversely impacted by COVID. And next slide, please. Our health and wellbeing network is the main point of access into community mental health services. And we wanted a single point of access to reflect a more sort of appropriate offer to our residents. And through Mind in Haringey, we support individuals with advice, support and activities aimed at building resilience and reducing the onset of mental health issues. So that is a very much a growing network of support that we think is fundamental to our community mental health offer. Next slide, please. I also want to highlight the work of Think in Space, and this is a program that's really close to my heart. It really builds on the strengths within our communities. We're very much supported by the Tavistock and Portman NHS Trust, but their work with residents within the community who have mental health needs through therapeutic sessions. There's an approach which supports people being trained and developed as facilitators for their own sort of group therapy. And this is something that has been going for some time, but it's something that increasingly, as we go through COVID, we feel has to be built on as we go forward. It is very much supporting our own sort of community to develop their strengths and to share within their sort of local communities. Next slide, please. Connected Communities is something that, again, was a program of activity that started probably about 18 months just before the pandemic hit us. But actually, we had plans to grow the project over a number of years. But actually, what actually happened with our COVID response is that we were actually able to expand very swiftly across the borough, bringing together council and voluntary services to support residents through a range of issues. You know, the everyday issues such as housing, benefits, financial advice, parenting, childcare, community activities. They were very much engaged in supporting people, delivering parcels, delivering prescriptions during COVID. And there was that ongoing helpline to deal with the issues that invariably were raised through the pandemic. Another area of support that has been developed over time is sort of their digital offer. And I'm sure many of you will be familiar with Kooth, Good Thinking, NHS Go, and how much the digital offer of support has really increased in emphasis. It's very much appreciated by the younger generations as well. And it's an area that we want to expand going forward. And the next slide, please. I've just given you sort of some examples of the work we're doing, and there are a number of upcoming mental health initiatives. But just to focus on an example of something we're doing this week in Mental Health Awareness Week, is really looking at how we can support through some of our everyday activities, whether it be food banks, etc., by putting cards, well-being cards with information within our food parcels. And they give tips about ways to promote well-being, as well as important phone numbers and links to advisors. We're also emphasizing creative activity during this week. And as we know, the connection with nature is a really important one. And again, that's something we are focusing on. Finally, in Haringey, I think it's really important, even though a lot of our offer during COVID has been through digital, just because of the necessary constraints. We've been able to develop in preceding months what we're calling our Haringey local living rooms. And those are opportunities where our local area coordinators have identified venues where people can just pop in on a regular basis. People know about the times that they're open. They're set up now in a COVID-safe pop-up arrangement. And it's not really about fixing problems, but it's really about the ability to talk. And we know how important it is to talk to peers, to professionals, to develop those principles of friendships, and for people to know that they're not alone in facing problems. And of course, the local area coordinators can then signpost on individuals to areas where there are more direct needs that are required. So there is just something for me, just to conclude in terms of the Haringey experience, just to take away an important principle that's very close to the way I like to work, and which has really been exemplified in terms of the approach London ADASS has taken to the celebration of Mental Health Awareness Week. We have created a series of videos with people with lived experience of mental health. They touch on themes such as stigma, taboo, personal responsibility, expectations from service. But it's always about building, understanding how we can increase and build trust and compassion within our services. And we're going to take those videos and the series of discussions we're having throughout the week, Monday to Friday, to look to see how we can inform and support the delivery of our offer to our residents in the community. And I think that's a fundamental way of working that I certainly embrace. Let's start with people with lived experience identifying the issues. Let's come together to work together to see how we can deliver solutions cooperatively. So thank you very much for just listening to my experience. I just want to now hand you on to, I think it's Jacob, is that correct? Who's going to share the next presentation. Thank you.
Great. Thank you very much, Beverly. It's a pleasure to be with you all this afternoon. My name is Jacob Diggle. I'm Head of Strategy and Insight at Mind, the mental health charity. And I'm going to talk to you today about what we have learned so far about the changing relationship between the pandemic and our mental health, and with a particular focus on the experiences of people with pre-existing mental health problems. For those who don't know, we're Mind. We're the leading mental health charity across England and Wales. And we work nationally, but also have a federated structure with over 100 local minds in communities embedded across England and Wales, delivering services and support to people with mental health problems. We have a wide range of service offerings locally, whether those are therapeutic services, whether that's advocacy or peer support or employment advice. But we also provide national service and support, including our information service that supports tens of millions of people each year, our legal casework, but also our policy influencing and our research work. And it's that I'm going to draw most heavily on today, and speak to you a bit about what we've learned from reviewing the wider evidence that Beverly's touched on already, but also from our own research into the experiences of people with pre-existing mental health problems during the pandemic. There's been a lot of focus on how the public's mental health as a whole has been changing, but we've been really interested from very early on, and we published our first research back in June last year, into how people with pre-existing mental health problems were being affected. And we're doing that 1 year on now. We are going to be publishing the next wave of this research next month. And so far, we've already had almost 15,000 people with mental health problems take part and tell us about their experiences. So I'm going to give you a bit of a sneak peek of what we're finding so far. Many of these themes kind of touch on what Beverly has said, talking about her experience in Haringey. I think it's worth reflecting on when we're thinking about this in Mental Health Awareness Week. We should be actually celebrating the fact that the general public has been remarkably resilient during this pandemic. There have been dips in public mental health, but given the scale of upheaval, the scale of the pandemic's disruption to daily life, and the grief and difficult experiences people are grappling with, the fact that we've seen only small dips in the general public's mental health and some quite quick recovery over time is really encouraging, and we should be celebrating that. But in doing so, we need to remember Beverly's phrase about same storm, but not the same boat, and recognize that the pandemic has entrenched pre-existing inequalities. And people with pre-existing mental health problems have been hit particularly hard. And I'm going to share some data on that in a second. We also know that those from racialized communities, those on low incomes, have had worse mental health before the pandemic started, but also have had greater pressures, whether those are economic, with greater unemployment and furlough within those communities, whether those are about COVID infections, and all of this is having a knock-on impact on mental health. We also know that those groups are already less likely to receive mental health support when they need it, and if they do get access, less likely to have good outcomes. So this is a really vicious cycle. We also need to pay real attention to the mental health emergency amongst young people. We are very concerned that there were already rapidly rising rates of poor mental health amongst young people under 25 before the pandemic started. And the latest data on this, and NHS data, shows that we had in 2017, 1 in 10 young people experiencing a mental health problem. So that's 3 in every classroom. And when that research was done again in the middle of 2020, we're talking about 1 in 6. So this is an emergency, and if we don't intervene early and provide effective support to young people's mental health, this is going to be a legacy that's with us for generations to come. As Beverly mentioned, a particular concern for those with pre-existing mental health problems, but this has been a risk factor for the population more widely, is isolation and loneliness. Now, that's been a challenge during lockdown with disruption to social support networks and people's routine, but we mustn't assume that when restrictions end, this problem will go away. And actually, our research is showing that there are real concerns amongst people with pre-existing mental health problems about how they'll cope with lockdown easing and the transition to a more open way of life and some of the challenges that come with that too. So we mustn't think that, we'll complete a vaccine rollout and it will be fine and everything will go back to normal. Actually, we're going to be having to provide additional support to people for years to come. A final key theme that really emerged very strongly from our research last year, and we've been concerned that it has actually got worse in the year since, is a very high rate of self-stigma. So people with high levels of mental health need, who really need support, both from the NHS, but also from other support services, feel that they don't deserve it. They feel like in a pandemic, when so many people are struggling, that they aren't special and they don't want to waste people's time. We know that people with mental health problems pre-pandemic already had very low rates of self-esteem, and self-stigma was an issue. And the pandemic has made that worse. And we're really concerned that this self-stigma means that people aren't reaching out for help, which means that their needs become more severe and more complex over time, and therefore it becomes harder to support recovery. In all of these patterns, these are kind of general themes that we're seeing emerging, but it's important that we don't think about the impact of the pandemic on our mental health as a one-off impact, but actually we think about trajectories of people over time. I just want to highlight this recent research that was published in The Lancet just 2 weeks ago, looking at the trajectories of different groups during the pandemic. You'll see from the bottom two lines that the majority of the population are in the consistently very good and consistently good mental health groups. So if you're a lower line on this graph, your mental health is better. And actually pre-pandemic, the rates of poor mental health are very low, and those have remained pretty stable and consistent over time. There's then a group which is labeled recovery here, and this is a group who tended to be younger, but still not in a very precarious financial position. They saw big dips in their mental health at the beginning of the pandemic in April, but actually have recovered quite quickly over time. The two groups that we're really concerned about, as shown in the dark green and the red lines, are those in the deteriorating and consistently poor group. And these are groups in the red line, those with pre-existing mental health problems, who are more likely to be living in deprived areas, more likely to be from ethnic minority communities, and more likely to be younger. And as you can see, that their mental health dramatically decreased even further in April and has remained very poor throughout the period. But we've also got this group of deteriorating mental health, and this is a group defined by economic challenges during the pandemic, where they'd really struggled to pay an unexpected bill. They saw small dips in their mental health as the pandemic started, and it's got worse and worse over time as they've become more and more precarious in their position. So when we're thinking about how to target interventions and support within communities, we need to be thinking not about a blunt measure of the impact of the mental health on the population as a whole, but thinking about those groups who are already experiencing pre-existing inequalities and those who've continued to deteriorate. It's not a simple picture. The final message I want to leave you with is that this is not all in your head. The psychological consequences of the pandemic are severe, and we should take a strong approach to it. But we already know that there's a huge mortality gap and a physical health comorbidities between those with and without mental health problems, which are being further reinforced and exacerbated by the pandemic. We know that the life expectancy of someone with a severe and enduring mental health problem was already 20 to 25 years younger before the pandemic. Now, when you overlay the fact that people with pre-existing mental health problems have been more likely to have had COVID, more likely to be hospitalized with COVID, more likely to die from COVID, but also some of the negative coping strategies around over and under eating, around drinking more alcohol, and around self-harm and suicidal ideation. These are all higher amongst those with pre-existing mental health problems. And we're deeply concerned that unless we have an urgent mental health support response from the government, but also from local communities, that this is going to widen that already shameful mortality gap and is going to be the longest and most devastating impact of COVID for the decades to come. So I'm afraid this isn't a very cheery picture, but I do want to remind everyone that we should be celebrating the fact that the general public's mental health as a whole has been remarkably resilient, but really focusing in on those who were experiencing mental health problems before the pandemic, who've been hit particularly hard.
Thank you very much, Jacob. Some really excellent statistics there that I think will hone our thinking and our response to the place where it needs to. Some really stark figures around people with deteriorating mental health. I'm really struck by your reflections on how people with mental health needs, increasingly stigma has increasing importance. And I think that's why all our campaigns are just so important, not just in this week, but going forward. So thank you very much for that. I'm going to hand over now to to Isaac, forgive me, from TLAP. Isaac, over to you.
So good afternoon, everybody. So my name is Isaac Samuels, and I'm a member of the National Co-Production Advisory Group, which is a group of people with lived experience. So I've been living with mental ill health probably all of my life, but spent many years in and out of hospital in the 90s and 2000s, and I, in recent years, have managed to not have so many hospital visits and had started my recovery journey. Then COVID came, and I don't know about any of you guys, but for me, my world overnight was turned upside down. It became very, very small. I'm talking to you on a digital platform today, but last year when COVID hit, I'd never been on Zoom. I'd never used any technology to support me connecting with anybody. I would spend a lot of time looking after my mental health challenges. Work was really important to me. Maintaining connections with my community was really important to me. And I developed this knowledge over about 20 years of knowing how to support my recovery and well-being. COVID hit. I was told that I needed to stay at home and shield. Didn't know what that meant. I was at the time receiving support from the community mental health team, and the doors closed of the community mental health team for all variety of reasons. I wasn't contacted at all. I was at home with very few choices around how I managed getting through this really difficult time, whilst having to try to, keep myself safe. Particularly as I'm not only living with mental health challenges, I live with other long-term health challenges, and I was in that high risk group. My partner was going to work. I was really fortunate that I had at least one person to talk to. I had stopped receiving all support because I didn't know how to receive support in a really safe way. I was really conscious throughout the early days of COVID that my feelings of wanting to end my life were really, really present, and I needed to get help. I called the community mental health team and got this voicemail with 5 or 6 different numbers saying, these are the numbers that you can contact. And I thought, this just won't do. So I contacted and reached out to a local charity, and their response was brilliant. Within half an hour, they'd connected me with a psychologist, and I was able to have a one-to-one meeting. The first half an hour was probably really difficult because I'd never used Zoom, so it was kind of getting on Zoom, all that kind of stuff. But I just felt, well, that's the response that I really needed. It was a shame that didn't come from social care or community mental health. I think over the year, I've been really conscious that I'm someone with no financial worries. I've lost all of my social connections. I've potentially now have all of these other health related issues because I haven't been able to engage in sort of my physical health support, and it's just been really difficult. Every day is really different. It's been difficult because actually all of the attempts to get help have just been so difficult. And I'm someone that has a support network. I'm somebody that can speak English. I'm somebody that can pick up the phone. And I just felt there were so many missed opportunities. Not all doom and gloom, though. I think for me, it was really positive to be able to connect to a local charity that I've been having one-to-one psychology every week. I've been able to have appointments with my GP. My GP's been fantastic. Out of hours, whatever I've needed, I've been able to develop a plan that's really supported me around my self-harm, because I'd spent many years trying to manage my self-harm, and COVID hit and it all came back, and it was a bit of a roller coaster. I think I'd spent so many years trying to avoid services, and services chased me. When I actually needed them, they were not to be found, which was just astonishing and remarkable in some aspects. I think for me, what has been really good, I think most people just want to live an ordinary life. I was probably one of these people that really valued connecting in the community garden, really valued work, and that just all stopped. So everything that helped me stay well just disappeared, and I couldn't see, what the reason for living was. And I was in a really dark place. Managed to get through that, and then I got COVID, and I ended up losing about 2 weeks of I have no memory of 2 weeks, and I was really scared to get help, to be honest with you. I was really scared to reach out because I thought, only if you're really, really sick, you should go to hospital. Ended up in hospital needing oxygen. And I thought at one point I was going to die. And nobody, even though I'm sure they had access to my records, and I'm very known in mental health services here, that nobody really inquired about my mental health. And I've been trying to rebuild some resemblance of a life before COVID, which is really difficult. Every day is a challenge. It could have been made so much easier with the right support. I'm fortunate I've got a lot of friends and family that have been trying to help, but I've not seen people for a year. I now know that this is going to be a long-term problem for me, because we've started to be able to move around a bit more. And even though I can go out and do things, I can't leave the house. I have such anxiety about leaving the house. People talk about, let's get back to a place of normal. My normal was, going to the community garden, being able to do some work. And I've been able to manage and maintain my work, which is great because of because of these platforms, but being able to connect with people. I've never been so lonely. I don't have the ability to connect with my friends because I'm still in that high risk group. I've had 2 vaccines. Now I'm living with long COVID, and I don't really know what the future holds for me. I worry about the impact on my physical health. I worry about the impact on my relationship. I worry about how I reconnect with people. I have extreme anxiety. And I'm someone that is able to draw on some support to manage that. I get really upset thinking about all of those missed opportunities. And I'm really grateful I found mutual aid. And mutual aid is something that just happened all over the place. And with the support of mutual aid, I've been sort of testing the waters. So I've met somebody in mutual aid and I'm kind of going to my front door now and they're having a bit of a chat with me. And it's made such a difference to me because those steps just seem so much bigger than I ever imagined them to be. It's not like having a mental health crisis. It's so different. So I'm conscious that I'm having a mental health crisis and my suicidal ideations all over the place and my mood and but actually that social ability to connect is just gone. I hope that this week really reminds us that there are many people that have ended up in hospital. There are many people that have unfortunately lost their lives. And for me, there were so many missed opportunities at the beginning of COVID, and I kind of made excuses, but we now are a long way in and I still haven't had any contact from mental health services. I've had a phone call to say, how are you doing? Left a message on the answer phone. I don't know what the future looks like, but I do know that there are going to be lots of challenges. And I think we need to start thinking about what do we need to do to support people like me, not only to maintain our poor mental health at this current time, but to start our recovery journeys again. Last year, my recovery journey just stopped. And then I had all of these other problems, such as not being able to connect with people, getting COVID and now long COVID. And I don't really know what the future holds. And every day just seems so challenging, but every day seems so, I feel so grateful to be here. So that's me, Isaac, and I just want to remind people that we really do need to minimise those barriers that people have to accessing the right support.
Thank you very much, Isaac, for sharing a very powerful personal story. You've put a human face to a lot of the statistics that we referred to, but you are living the experience, and I think all the points you make are really important ones that have to be responded to. So thank you very much. I'm now going to move on to Kieran from NHSE.
Hi, thank you. If I could ask my slides to be shared. I'm Kieran Bangu, Programme Manager in the National Adult Mental Health Team at NHS England and Improvement. And I'm going to be talking about the Community Mental Health Programme. This is a wide-ranging transformation programme that has just had its national rollout as of April the 1st. So go to the first slide, please. Thank you. So within the long-term plan, there is the flagship commitment around supporting an additional 370,000 adults and adolescents who've got severe mental illnesses to be supported to access new and integrated models of care. So this is across primary and community mental health care, so they can have greater choice and control over their care and can be supported to live well in their communities. And in order to do this, we've got almost £1 billion going into invested into community mental health services per year by 23-24 to support us to achieve this vision. Just want to say thank you so much to the previous speakers, because I think they've really helpfully illustrated lots of the reasons why this transformation programme is so important and why we need to make the changes that have been laid out in the long-term plan. So the next slide, please. Thank you. So there's a number of commitments within the long-term plan which kind of are all together can be taken as part of the community mental health transformation programme. So there's the core model, which is the new kind of integrated models, which are sitting across primary and secondary care, which will be contributing to that 370,000 minimum access number. And then within that, there are a number of dedicated focus areas. So we'll be improving access and treatment for, again, adults and older adults with a diagnosis of personality disorder, those in need of mental health rehabilitation, and also people with adult eating disorders. Alongside that, we're also increasing the number of people with severe mental illnesses to receive a comprehensive physical health check to a total of 390,000 people per year, supporting an additional 55,000 people to participate in the individual placement and support program, which is around employment services, and also maintaining the 60% early intervention in psychosis access standard. Next slide, please. So I think as the kind of previous speakers have already illustrated, there are lots of reasons why people that are accessing community mental health care at the moment don't feel that it's at its best, and the improvements need to be made. So at the moment, there are very much kind of siloed care pathways, people accessing services when they reach a specific threshold rather than when they're presenting for specific support. There's long waits for access to community mental health teams, rejected referrals are being pushed from pillar to post between primary and secondary care. Lots of different teams, so people with very complex needs again need to be kind of seen by multiple different teams that aren't very well integrated, and obviously there's different exclusion criteria between these teams. So one of the terms that we seem to see is a team for everything but a place for no one. There also is a very, very complex navigation of the whole care system with repeated handoffs between teams. And this is very much constructed around the services, which may be to do with the fact that resources have been very limited so far, so users aren't really at the centre of that. There's also a lack of evidence-based treatments and long waiting times for people needing psychological therapy. And I guess underneath all of this, just minimal meaningful care contacts and people being treated as risk entities rather than in a personalised way. And then also just people left to be finding the kind of support for social needs completely on their own and completely separate from this existing care offer. So what we want to move towards is much more integrated support between primary and secondary care, and help for people to be able to access support as and when they need it. So care can be stepped up and down according to their need. And an end to blanket discharges where people are kind of left feeling unsupported if they've got to a certain stage in their recovery. We're also looking at much shorter waiting times and potentially introducing a nationally mandated 4-week waiting time. And this is subject to an ongoing programme of work around the clinical review of standards. The removal of all arbitrary exclusion criteria and a move much towards proactive and inclusive care, including for people with coexisting needs. People will have a single named key worker, and that model of care will be designed around them and for them. Much more improved timely access to psychological therapies, and a much more personalised approach that addresses needs and is not diagnosis based, and bringing in system partners such as local authorities, the voluntary community and social enterprise sector, and anybody else within a local system that can be used to support people with severe mental illnesses. And next slide, please. So just in terms of where we've got to so far, so since April the 1st, all ICSs across the country have been awarded transformation funding to deliver this new model of care. So this is following a 2-year pilot phase. So from 2019-20 and 2020-21, 12 early implementer ICS sites across all of the 7 regions received a portion of £70 million of funding to pilot these new ways of working. So the idea was that there's a 2-year testing phase, lots of different models were being tested, and we would be able to then see what was working well, what some of the challenges and barriers were. And through that process, we have very much seen, what's important to have in place to ensure that successful implementation, but also the things that make things much more difficult. So all systems over the last kind of between September 2020 and January 2021 took part in a very, very detailed planning process to really set out how they were planning to transform their mental health services, and have been awarded transformation funding on that basis. So as you can see from that table, the funding profile very much goes up over the 5-year period. So by the end of 23-24, there will be almost £1 billion going into community mental health services. Obviously, as colleagues have already said, the pandemic had a really big impact on the pilot phase, and for a short period of time, some systems had to pause their transformation work. And that was also delayed through the 2020 pandemic period. So we've been working really closely with those systems to try and recover, and also sharing and gathering the really key insights around what are the key ingredients for success to make this work. Next slide, please. So this is a slide just detailing some of the key things that need to be in place in the core model, and also in each of the dedicated focus areas. So this is through conversations we've had with the early implementer sites, with their regional teams, with partners that have been working across all of the sites as well, just to lay out exactly what we're looking for in each of these areas. So within the core community model, this is very much about a fully transformational model, not just looking kind of tinkering around the sides. It's very much needs to be integrated across primary and secondary care. So not creating additional teams within secondary mental health care, not creating a new primary care mental health service. This is very much about integrating what already exists and using existing community mental health teams as the basis of that. Recruitment and workforce is a really big challenge that has been highlighted throughout the programme. Especially thinking about the numbers of people that will need to be recruited, and the kind of amount of funding going into systems, and being able to use that in a way that is going to give kind of patient populations the workforce that they need. So this isn't just about recruiting in those kind of traditional clinical roles, but thinking much more innovatively around those non-clinical roles, peer support, and any other roles that would support this new way of working. And then around the dedicated focus areas, there are a number of things that really kind of sit across all three. So thinking about those kind of therapeutic relationships, again, workforce that's effective and diverse and reflective of the population, and should include that non-clinical element as well. And thinking specifically around kind of how the model should work. So early intervention, and then thinking about those access thresholds, and really kind of getting rid of those. So for eating disorders in particular, thinking about BMI and weight as not a threshold for access to these services. And then generally a really strong MDT approach. So ensuring cared for with the right people in the room, having a number of different disciplines within that team, depending on the personal needs of that person. Next slide, please. So we have got a number of kind of key messages that we've been sending out around things that systems should start to have in place in order to ensure successful implementation. So the first thing is around commissioning. There are significant amounts of funding going into systems, and systems should think about those key contracts that need to be in place to deliver this, and that includes integrated commissioning with local authorities. Partnerships is really important, so developing those as quickly as possible. Recruitment, I've already mentioned, thinking about that as early as possible, and being able to develop a workforce model that is right for your system. Leadership, this needs to be a kind of senior level owned thing across all system partners. Lived experience is again really key, and this should be underpinned through the whole transformation and be embedded at every single level. And finally, governance to really support this. Next slide, please. Thank you. So these are again some more messages that we've been sending out. I think I've said most of these already, but just to reiterate that the partnership point is really important. And what we found from the pandemic period is those early implementer sites that had those mature partnerships in place already were able to use those and kind of work in a flexible and dynamic way to respond to the needs of people through that pandemic period. And then finally, I think I've got a Q&A slide, but do stick any questions in the chat, and also I'm happy to answer questions at the end as well. Thank you.
Thank you. Thank you very much, Kieran. Thank you for taking us through the community health plan. I suppose the point that really speaks to me there from your brief summary is really the importance of co-production, so that we can ensure we respond to local need. And I think that's a theme, that's a big takeaway from the conversations that we've been having. So thank you very much. I'm going to move on now to Mary from the Oxford Health NHS Foundation Trust. Thank you, Mary.
So thank you. I'm Mary Buckman. I'm the Associate Director of Social Care for Oxford Health NHS Foundation Trust. and we're a large mental health and community trust, largely covering Oxfordshire and Buckinghamshire, but also providing CAMHS mental health services across Wiltshire, Swindon and Bath and North East Somerset. I'm also the co-chair of the BASWA England Mental Health Special Interest Group. So I'm going to start with just talking a little bit about the Community Mental Health Framework. You've already heard details from Kieran. If you are less familiar, I have included some links to various things in the last slide of my presentation, so not sure if those are going to be shared later. But in summary, from the Community Mental Health Framework, it is about a place-based community mental health model and how community services should modernise to offer whole person, whole population health approaches aligned with new primary care networks. It's really an integrated approach, providing benefits for both users of the service and staff through integrated assessment, fewer referrals, and more direct contact time between staff and people using the services. Now, there are many synergies for social work with this model, and many have observed in some ways that the model itself could be describing mental health social work, seeing the person in the context of their family and community and taking the wider context of their lives into account, really thinking about personalisation and a strengths-based approach. It's therefore very important to make sure that when NHS trusts are moving forward with implementation, that their local authority partners are involved in the design of new pathways. So with thinking coterminosity, if possible, is helpful. With the Community Mental Health Framework services designed around primary care networks, they may or may not align with how adult social care services are deployed at the moment. Referral and assessment pathways are also key. How we ensure that people being referred for mental health assessment and support also have access to social care information and advice, and an assessment under the Care Act, if appropriate. Now, these issues need to be built into pathways and included in service planning from the beginning, not added as an afterthought, added extra at the end if it's suddenly realised that it wasn't considered. Now, I would hope that local authorities are being part of those local system discussions and part of the planning for service delivery, but if not, very much suggest engaging with local trusts, ensuring that social care is part of the planning, not the afterthought, as I've just mentioned. Now, some trusts were part of a programme of pilot sites, as you've heard from Kieran, and others, the majority of them are now currently in progress with implementation. The next slide, please. So I was also asked to think about what we've learned from the pandemic as a mental health trust. Now, much of this, I'm sure, isn't unique to us and will be shared across agencies. And what we had initially was we found we had the ability to pull together a very rapid response during the first lockdown. We had a shared goal of working to create capacity, particularly within acute hospitals, not only physical care, but also in terms of our mental health inpatient services as well. And that work was largely focused on facilitating discharges from inpatient care, trying to create the capacity that was anticipated within acute hospitals. We were largely using a discharge to assess model, and that demonstrated what can be achieved when system partners do work closely together with providers to achieve their objectives. However, that example has also taught us that arrangements made quickly also need to have review schedules and responsibility agreed at the outset to prevent any surprises down the road. If we've placed people very quickly, we've removed all the usual assessment and decision-making about funding barriers. When will those things actually take place? They're still needed at some point in our processes. Care and support providers are also key partners in this work. We're all familiar with some of the challenges that were faced with regards PPE and appropriateness of placements when we were placing people quickly. It's really important to include providers in the planning of the work. Now, one of the challenges we've got with that, I've just described a piece of work about creating capacity within NHS services, and sometimes those pieces of work can reinforce perceptions that social care exists to support the NHS with managing inpatient capacity. And it's important that similar pieces of work are undertaken on the basis of equal partners, and that social care has its own priorities and its own functions supporting people in the community to live independently. Now, by working together in this way, any barriers to putting services into place and supporting service users are able to be addressed. And that was about having the right people at the right level involved in regular, in our experience, often daily reviews, able to give a focus to who needed to do what. In many ways, we think that was an extension of what's within NHS terms is often called red to green days. So for those unfamiliar, that's a programme of ensuring that inpatient stays are productive, that we're not wasting time into putting into place what needs to be done to support the person in the way they need to be supported. So again, I've put a link to that describes red and green days on the last slide of the pack. Coming on to virtual contact in the next slide. In terms of then flexible working and our staff support offer, which are very much linked together, and similarly to many organisations, we were able to rapidly put in place flexible working for staff. Those who didn't have access to required IT were provided it within a very short timescale, and what had been until then a relatively limited use of Microsoft Teams became our main way of working, not only for meetings, but also work planning and file sharing. Many of our patient-facing staff have, however, always had to be in their workplace, whether that's on our own wards or in our community teams and day services, although we have run some of our acute day hospitals virtually as well. Now, as an organisation, we were able very quickly to address the psychological support needs of staff with quite a varied programme of wellbeing, one example of which includes taking the equivalent of Schwartz rounds called Team Time, developed by the Point of Care Foundation, into the virtual space for managers of our acute mental health wards. Now, for those people, it was really incredibly important to have a safe space with which they could reflect, they could support each other, we could support them with the challenges that they were facing on a day-to-day basis. Now, the staff support offer and flexible working can't be seen in isolation. Not every member of staff has an appropriate place within their home to work. We've already heard the phrase that we're all in the same storm, but in a different boat. And that's the same for professionals and staff as much as it is for people who use services and the wider community. Some live alone, could be experiencing isolation themselves. Many were supporting other family members at the same time. Now, the programme to support staff to return to working in an office space at least part of the time is ongoing currently with our estates team, considering how we can maximise the benefits where people have really appreciated and want to continue working with a more flexible balance between home and office, while ensuring that staff support and supervision is in place. And as we heard from Isaac's own experiences, none of this has been easy. We can't say we got it right all the time. And in trying to respond and react and putting new systems and processes in place, one of the risks with that is that some things might have been lost along the way. So it's really important to ensure that that hasn't happened and that we're still supporting service users as well as staff. The next slide, please. I'm going to use an example from one of our services. So these are our child and adolescent mental health services in Oxfordshire, just to demonstrate how contact with people using the services, so the young people and their families, changed over the duration of the pandemic. So much, as I've already said, was adapted in a very short space of time in the first lockdown. But we can also use that experience to inform how services can continue within the virtual space and support wider engagement. So we've learned we've got the technology and flexibility to offer different forms of contact. Now, our CAM services particularly are saying that parents have required a lot of additional support during the pandemic, and services have pulled together support offers, including, for example, online groups. But alongside this, however, again, the theme, same storm, different boat, we can't ignore the disparity for many of the people we work with across needs groups who may not have access to technology, either as a result of the access to IT, broadband, or indeed the impact of their presenting needs. It might not be an appropriate way to communicate. It might not work for them, however convenient it might seem on the surface. And the pandemic has also emphasised what we already know in terms of how organisations work across service boundaries to meet people's needs. Now, whether that's across health and social care, whether that's the third sector, and whether that's just general community services. So whilst our services may have been continuing to offer a degree of face-to-face contact, many of the people we support also rely on those other services as well, whether they be specialist mental health or other general community services, clubs, social settings, groups, even just seeing their friends, their usual informal support networks. They haven't always been able to stay open, or during lockdowns, people haven't been able to have contact with their family and friends. So many of them haven't been able to move into the virtual space, which, as I've said, doesn't meet everyone's needs anyway. And for many of the young people our CAM services work with, education is such a key element of their support plans. And also where new packages of specialist residential support have been needed, this has been even more complicated than usual.
Thank you very much, Mary. Some really important issues there. I can pull out the importance of partnership, the importance of social care and the role of social care within any systems response. And very much I would agree that certainly during COVID, we've moved from contact with providers to building relationships with providers. And hopefully that's something that we can retain going into the future. But thank you very much for your presentation and the list of resources. I'm afraid we're running a bit short of time, so we're going to have to cut the Q&A public session a bit, but I can assure you that ADASS will get any responses that we're not able to cover in the allocated time over to you. But now I'm going to hand over to Jim, who's going to take us through the public health perspective. Thank you.
Hello, folks. I'm going to try and get us a little bit of time back. So I'm hoping you can see my slides because the less I speak and the more speakers keep down, the more time you'll get. Basically, I'm just going to cover why public health and social care should work together and what we can add out of it. And I'm going to make 6 key points. The first is that ADPH recently published our COVID endemic environment guidance. You might have heard government talking about living with COVID. That's where our stuff came from, and that's where government got it. The idea that COVID will be endemic for a while. You add to that the fact this morning the Centre for Mental Health published a key report on mental health need from COVID, and then you add the stigma and the collective trauma and various other things. And we are heading for multiple whammies of public health needs. You can read these slides at your leisure. And so we can't treat our way out of that. More than ever, we need a multifactorial approach to stigma, to resilience, to coping, to early intervention, and to stratifying people. So we cannot treat our way out of this. And the question starts for us. How do we make sense of what has happened at population level, which Jacob started? What does that mean for individuals that Isaac elucidated far more eloquently than I could? And how do we make sure that every workplace, school, community and setting is a mental health promoting setting? So local authorities and place come to the fore. And we have to place health and care services in the context of our population approach to better mental health for everybody that includes work, employment, growth, and safety and stigma, and not the other way around. COVID is a pandemic, but it's also a syndemic, the idea of multiple waves. So waves of psychological trauma, waves of unmet need and displaced need, waves of people having the impact of joblessness. These are all going to have to be factored into our plans for recovery. And my suggestion is that we work together using the best of what public health can offer, which is the synthesis of evidence and local information in need, with the plus our services, with the best of your services and intelligence and community knowledge. I'm going quickly through this, but I'm going to make my main point per slide. Most of us will have seen the PHE report on the impact of Black, Asian, minority ethnic communities from COVID. If that doesn't illustrate this endemic impact of COVID, And the fact that going forward, we absolutely must have a full response to this, because COVID is not an equal opportunities impactor, and neither will be the long-term sequelae of it. The virus had its highest burden on those who have least ability to resist it. And that will be the case going forward. And if we get a third wave, those who bear the highest burden will die first from the virus. And that includes those who are not vaccinated. And that includes people with mental health issues. So I think we have to take a public health approach. And I think it's time for us to work together on kind of resetting what we can do. And there are 6 key points, I think, to population health approaches and priorities for here. And I'll run through that very quickly. I've said we can't treat our way to good population mental health. So we have to actually look at the whole spectrum of need, from flourishing and resilience right through to resilience and recovery. How do we make every employment setting somewhere where we can intervene? Before I joined this webinar, I was on one with our fire service, where we had people in the fire service who'd been through burnout and through PTSD this last year, discussing their approaches. And we have started a process together of making our fire service a resilient and trauma compliant service. They're doing great guns. We need to do that more often and everywhere else as well. I won't labour that point. Really good diagram here for public health and others for planning services, that some mental health need was suppressed by COVID and existed before, and there's been a lot of it generated by it, just grief and bereavement alone. And that should give us a real sense of looking at the collective trauma that has happened. And it is a collective trauma. And we do need to understand, I think, the psychology of collective trauma and what that means about all our services. You may be seeing at the minute grief turning to grievance, where people are becoming very angry and very polarized. That's just one of the impacts of not dealing appropriately with collective trauma. And we have to do much more. I'll skip over this slide other than to say that a key lens for public health is looking through a life course. And this joint LGA ADPH Hertfordshire slide tries to give a very quick ready reckoner to some of the differential impacts of COVID across the life course. I think I've covered that slide about the public health matrix. So I'll just go on and talk for a few seconds about what we've done in Hertfordshire. We've set up a public mental health network, which has now gone national on Knowledge Hub. So you can find it on Knowledge Hub. It's called COVID Public Mental Health, and it has resources there about responding. But we've actually taken a public health approach, which has resulted in everything from resilience training in schools and for staff, to actually trauma training for care home staff. We're in the middle of that at the minute. Unfortunately, they have to put up with me teaching some of the sessions on trauma. We have a session called Why Zebras Don't Get Ulcers, which is an attempt at introducing the science of trauma to care staff in a way that actually helps, and has been co-designed with them. And our Care Providers Association has been amazing in working with us on that. We have a range of interventions for employers, including work through the Growth Hub. And we've done significant amounts of behavioural science work on building confidence and helping people cope during lockdown. If Isaac's story tells us anything, it tells us that we have 1.1 million people in this country with long COVID whose need will add to the existing need. And we can't treat our way out of that. We have to find a better way. So now more than ever, we need to find public health approaches. And as part of a public health roadmap, I'd like to suggest the use of this syndemic lens, much more work on resilience and recovery together, because we will have more frequent syndemics. They are coming now every 9 years, but not every 30 years. So this will come back. So what can public health offer? Well, walk down your corridor and have a cup of coffee with your Director of Public Health. And if you want me to, I'm very happy to do a much longer exposition of this that is much more practically focused when time allows. But I'll stop there at 7 minutes, 50 seconds to allow time for some of the crucial questions. Thank you for listening.